For joining, everybody. Yes, so I'm Jane, who's the lower person on that list. So been a learning disability nurse for many years in Herefordshire, and current role is learning disability acute liaison nurse at Wye Valley Trust. Sam and I are in a job share in that role. We split the week between us. And as it says, Sam's other hat is community learning disability nursing, which was my former role in Herefordshire. So, we're a fairly experienced team. So yeah, next slide, please. Yeah, so I don't know, is there one with learning objectives? Just go back one, sorry. Okay. So I won't read all of these out, but we were asked to present on some of these issues. So, we'll talk about who we are, what we do, some of the differences between some of the definitions, which I think is helpful because there's sometimes some confusion. We're going to talk about pathways, processes, key messages really that from our experiences of supporting parents with learning disabilities, what we've learned over the years, touch on people's capacity, learning styles, reasonable adjustments, and we'll throw in a few sort of resources that are useful to refer back to as well over the course of the session. So hopefully that's what everyone is here for. So that's good. So next slide, please. So I think it's useful just to tell you about the learning disability health teams in Herefordshire. So as I said, we've got the acute liaison service. We've also got a adult community learning disability team. And obviously there's children's LD and disability services. But predominantly Sam and myself work with the adults. So I think the key messages are that the purpose of our team is not to replace mainstream health services for people with learning disabilities. Our main aim is that people with learning disabilities access mainstream health services wherever possible with reasonable adjustments made. So very much that's the first line. And then we often give advice and guidance to mainstream services about how to meet that need, much as what we're doing here on this session. It's only at that point, if people then really are struggling to access the mainstream services, we will pick up the referrals and work in a much more bespoke way to try and meet that need. But again, still in conjunction with mainstream services. Gone are the days where people with learning disabilities lived in an institution and had all their healthcare needs met there. We now are encouraging, we're not experts in physical healthcare, we're experts in understanding their learning needs and helping them get the best out of things. So it's about that collaboration. We're very much moving towards an MDT approach. And as I said, that advice and guidance. So over the last couple of years, we've set up a lot of MDT meetings, for example, with the GP surgeries, the local PCNs. We have regular meetings with most of the GP surgeries. We have meetings with the epilepsy specialist team, the diabetes team, where we can talk about shared patients and help support them through those specialities. We only support people who have a learning disability plus other health conditions. So that's the first criteria. So they may have autism, but they've also got a learning disability. They may have a mental health diagnosis, but also a learning disability. We have recently set up in the last 12 months a dementia pathway for people with learning disabilities, because it's a much more complex situation to diagnose dementia in someone who's already got a cognitive impairment. So we've got a team working on that. But again, that's dovetailing into mainstream services. We're not doing it standalone. So I think that's the key message there. So as you can see at the bottom of the slide for future, if you need more information about our service, there's a link there. Okay, next slide, please. This is just a quick slide for you to refer back to. This is myself and Sam, who job share the acute liaison role at the hospital. It basically tells you on the poster what we do and how to contact us. We were a bit younger and less grey hairs then, I think, but back that was 6 years ago when we started the full-time post between us. But yeah, we do encourage that we're contacted because, as I said, between us we've got a lot of years experience with people with learning disabilities in Herefordshire. We quite often know them, you know, they're a group that don't change a lot, so we're a good port of call for advice and support if we can do that. Yeah, so I think that's just says all it needs to say on that slide. Just to say there is no cover for this post when we're on holiday or sickness. So it's a full-time post, but it doesn't cover holidays or sickness. So there may be some gaps which we'd like to address, but resources don't allow at the moment. So next slide, please. So I think it was useful, you know, we're talking about resources and what's out there. It was useful just to mention there's a few specific learning disability type resources that we have in our community learning disability team that we've successfully used with parents who have learning disabilities. So just jumping down to the second point, the baby simulator, we managed with charitable funds to purchase one of the interactive babies that, you know, you can give to a prospective parent to find out what it's actually like to live with a baby. And we've used that with some of our parents quite successfully. It's just hard to know how to shut it up in the office when you haven't turned it off properly and it's still crying in the cupboard. But so that is a resource we have, you know, and we're very willing, if we're working collaboratively with prospective learning disability parents, to look at loaning out these pieces of equipment to support understanding, learning and reasonable adjustments. The top bullet point is a link to it's a full pack of 3 booklets that are easy read, simple language, that support parenting journey. So the first booklet is about your pregnancy. The second booklet is about a child 0 to 1 year old, and then the third booklet is about 1 to 5 years. And we've lent those out extensively to midwives, health visitors, because some of the more mainstream parenting literature and resources are far too complex, wordy, for some of our patients that we support. So we've used this successfully, and the style of the resource is that it's a loose leaf folder. You can pick out elements that you want to discuss in a session. You can photocopy those loose leaves and leave that information with the parents so that they've got something to refer back to. So I think, you know, for example, the Solihull parenting style parenting training, you know, it doesn't always lend itself to being, you know, I've certainly used it with women that have been to parenting sessions, and it's, you know, very wordy, you know, a lot of information presented to someone in not necessarily an easy read format. So we have got that resource, we do lend it out, but I think we've encouraged services to look at purchasing a pack because they can be shared as a resource amongst big teams. So I think that's a takeaway. Have a look at it, see what you think, because I think it's a useful resource to consider buying. And obviously the bottom one again is a link to our community team, and we do have useful stuff on our website about easy read, etc. So it's always worth having a look there. Okay, yes, thank you. Next slide. So I think it's useful at this point, maybe we should have done it a bit sooner, but just to have a little definition of what we would say from our service point of view means learning disability. So this comes from, you know, Department of Health, Social Care, World Health Organization. These are long-standing definitions, but essentially, and we don't always have all of this information, but essentially we're talking about someone who's got an IQ of 70 or below. So that functioning is fairly low. As I say, we don't always have an IQ. They have a reduced ability to cope with life. And the onset is early. So we're talking about the children that haven't met their milestones. It's apparent from a very young age that they have a cognitive impairment. So we're not talking about people with acquired brain injury. We're not talking about people with a degenerative condition that were of normal cognition at birth. And that, you know, it's got to be a condition that they have essentially been born with or has happened during birth. So we need all three of those really to define learning disability. And that is the criteria for access to our learning disability service. And we can have a whole range. We've got very profound and multiply disabled people that we support. We have people whose IQ is 69 and live on their own. So it's a very wide ranging net we have. So next slide, please. So I think this is where sometimes we get a bit of a blurring. So a learning difficulty. Oh, sorry, we've got a bit of an echo there. You know, we sometimes get people referred to us, and is it a difficulty? Is it a disability? And we have to unpick it. But for example, all of these conditions that are listed here, a lot of them starting with D, I've just noticed, but you know, they do still need services to make reasonable adjustments for. You know, they still need things perhaps given to them in a different format or longer appointments. That, you know, it's all still important things to recognise, but they wouldn't have a diagnosis of learning disability. That's just to be clear there. So I think it's important to bring it up, but you know, from our services input point of view, we would try and, you know, look at what the actual need is. As I said, from your point of view, it's still about the adjustments you might need to make for any difficulties they have. Learning Disability Register as the first hyperlink. So basically, there's just quickly, all GP practices are contracted to provide annual health checks to people with learning disabilities over the age of 14. So it's a chance for an annual review of all of their health needs, because they're generally a population that often don't recognise their own ill health or health promotion initiatives, and often have undiagnosed or untreated health conditions. So that's a really useful way of trying to meet unmet health need in the learning disability population. So GPs are encouraged to hold a register of their learning disability patients so that they can be watchful on their health. Okay, so next slide, please. You know, this is a vast subject covered in one slide. We could never, ever do it justice. It's important to say again, from a learning disability perspective, we do work with people that are neurodiverse as long as they also have a learning disability diagnosis. But obviously this has become much more apparent. You know, there's much more access to assessments for neurodiversity now. But I think for me, the issues here that we see are there's a lot of access to diagnostics, but support for the neurodivergent community is sadly lacking. And I think there's a lot of way to go to make health, social care, and all public services much more aware of their responsibilities to this group of individuals. I could talk all day about it, and I'm sure there's people on this, training that have their own experiences or may even have neurodivergence themselves, and it's a massive, massive subject. But I think from what we're saying here, this is bringing us back to subject today. We're talking about this is another group of people where we must be very clear about the adjustments we need to make to our working practices to ensure that these people have a fair and equitable service from us. I think that's the key message here. And as I said, if they've got a learning disability as well, that's often, makes their barriers much higher to accessing good quality care. There's some links at the bottom. That's the one that says catalogue. It is an NHS link to some information about neurodiversity. And there's also the one at the bottom, so people can look at that at their leisure. Thank you. Next slide, please. Right, okay, that's enough of me talking for a moment. I think what we'd like to do at this point is just throw the floor open to the participants and just have a little thought for a moment. And if people want to either put it in the chat or if they feel they want to speak on the call, that's fine as well. Just have a think about where in our current practice do we perhaps unintentionally create barriers for parents with learning disabilities, and what might we want to do to think about removing them? Yes, we've got a hand up. I don't know if Natalie or Kirsty want to sort of facilitate this bit for me so I can have a drink.
Yeah, so over to James Tappin, you got your hand up? Oh, you're on mute, James.
Hi, yeah. Something we try and mitigate for is our teaching styles when we're training our volunteers and like new members of staff potentially, is the fact that we might be teaching in a very specific way. It might be too wordy or it might be too visual. We try and mitigate that by offering as many different formats and using as many different styles as possible, just so the same information could be put across to, in 2 or 3 different learning styles, 2 or 3 different type of people. And that's what we try and do. I'm not saying we're always perfect at it, but that's the intention anyway.
Thank you. Yeah, that's great. Like you say, taking in people's individual needs and how we present that information. So thank you very much. Yeah, in the chart in terms of some of the barriers, we've got overloading people with information. I'm sure a lot of services we could put our hands up to that one. And certainly if we think about reports, certainly in sort of children's services, when we write reports, you sort of got to think about who's the audience, and maybe sort of considering alternative formats or summaries of big reports that we may be writing. Yeah, so we've got to be very careful about that. Expecting people will be able to understand and know about processes. Yeah, so again, I think whatever service we're in across the board with everybody here, we're all going to have our own individual processes, and that's going to look different. And especially if parents are going to be working with lots of different services, that could be very quickly become overwhelming. If we just think about ourselves as professionals and understanding, like me trying to understand the NHS system, or the NHS trying to understand children's services, adult services, it could be very confusing for us as professionals, let alone parents with learning disability as well. Yeah, so using too many acronyms, we're all very guilty of this. Yes, definitely. I've certainly, again, attended meetings where acronyms, names of teams as well. I've recently, I say recently, I've been here about 6 months now, but joined Herefordshire Children's Services, and just knowing what the different teams are, what they do, maybe what different roles do, and understanding that those acronyms, definitely we're all guilty of doing that. language and terminology and time. Yeah, so again, often it can be they may have set appointments, and actually you've got your sort of your slot of 10 minutes or your half an hour or your hour for whatever you're trying to explore. Just thinking, actually, is that enough time for this parent? Do we need to be making those reasonable adjustments, as Jane's highlighted? Parenting groups, yeah, aren't always as specific for learning disability. And yeah, Jane, you sort of highlighted that, haven't you, in terms of the Solihull approach or whatever other groups, yeah, are they sort of meeting that need? Face-to-face conversations help, and asking who they would like to present with them. Yeah. So just looking at what support's there and to help them. So some really great points there, everyone. Thank you very much for that. Back over to you, Jane.
Yeah, I'd just like to say, those are all really good points. And I think it's hard, isn't it? We're in a time pressured, public services, NHS, social care, whatever it is, there's never enough time for anything, isn't it? So, being able to ring fence time for someone who needs those adjustments can be difficult, and we can meet barriers in our own services when we're asking for that and not getting it. Getting support. So I think it's really, really hard, and I think that face-to-face thing, I think in a fast-moving NHS in particular, I'm battling all the time, our patients are getting text messages about a point, they might not even understand how to navigate that on their phone. They might, we're losing touch with that human element of stuff that actually some of our patients really need and some of the people we support. And I think time's key too, because sometimes you can set aside a lot of time, but actually someone can't manage to retain their concentration for a long period. So you might need to do a little, but more often. And that is where we're looking at that person-centered approach and finding out from the people who know them, how is the best way to support them with this so that I'm not putting another barrier up, but it's really encouraging in the chat and people's comments as well that, that people are thinking about that, that's a great start, isn't it, really? So thank you for that. Okay. So sorry, just get back to my notes. So I think these next few slides is really just, when we've sat and thought about Sam, myself and some of the community team that have supported parents over the years through the parenting process or through pregnancy, these are some of the pitfalls that we've seen and the learning that we've had, so I think these are really good to share. And I may be preaching to the converted here, but I think it's good messages to keep bringing ourselves back to. Okay. So I'll just quickly go through them. So considering their learning needs as early as possible, I mean, I think that's a no-brainer, but I think sometimes our experience is that, things like cognitive assessments often don't get triggered till quite far down the process when baby's due in a few weeks, and actually then all the information that parent has needed has not necessarily been in the right format for them from the start. We're working back in the wrong direction. And again, this is where our team might be able to help. We might have stuff on file if we know these people about how they learn, their learning style, preferred way of communication. So it's always worth reaching out to the specialist services. If we've got it, we can look at sharing that with their permission to help them with the process. Ask the patient directly, ask the people who support them. They'll probably know. They'd rather do face-to-face. They can only manage 10-minute chunks of information, or actually, they read and write really well, and actually they'll manage with normal literature. Look at education history. Are there any things there in their past that are going to give us some help? Have they got any HCP? What support they received in the past? Check if on Learning Disability Register. We're multi-agency. We've got colleagues we can check in with. You've got a feeling, check in with GP that whether this person, you know, probably is going to need some extra support and adjustments made. Again, look at previous documentation if you've got time. Contact the LD team. Do we know them? You know, can we support? You know, and quite often my experience is Sam and I will get a call. You know, this doesn't happen so much now, thankfully, but we've got a lady on maternity. She's just given birth. We think she's got an LD. You know, and I don't, you know, what can we do at that point? You know, we've not been involved from the start. It's like when we get called because a patient's distressed in one of the wards at the hospital. They've been there 2 weeks. We didn't know. We could have done something to stop them getting distressed in the first. It's about being proactive, isn't it? Sorry, did someone write something in the chat there? And I not gonna. Someone.
Yeah. So
Yes.
somebody's put, sometimes it's difficult when needing to re-explain an information sharing with services. I supported somebody attending A&E, and although they are on the LD register with the GP, that information hadn't been passed over. And because of their complex needs, they found it difficult to manage that environment, and therefore the need to re-explain their needs, which can then become a barrier to accessing services, as they were put off going again. That impacted their experience.
And I think that's where, so just we'll touch on this because it's relevant to the point that's been made. So Sam and I are able to add alerts to the hospital records if someone has a diagnosis of learning disability. We'll put it on if someone has autism, you know, we can add them on even if they're not under our service. A&E have one computer system. This isn't bonkers really, and the inpatients have another, but we can add an alert to both of those. And we do encourage our learning disability patients to have hospital learning disability passports that they can present when they arrive at hospital, that can highlight to the staff what their needs are from the outset. So if anyone wants to have any specific conversations, you know, about how to access that, about individuals, then feel free to contact Sam or I on our contact details and we can support that ongoing. Someone's got their hand up.
Yeah. So Sophia?
Hi. Hi, Jane.
Sophia.
Hi, how are you? Thank you very much for the presentation. It's lovely. I just have a question. I think, you know, a few of my dental colleagues are on the meeting as well. So I'm pretty sure that they would have the same concern that I have now. So you know that we don't work out of Maxims or any other IT program that you guys work at your hospital. So we have a dental program that is very dependent, and the information that we get there is very dependent on what actually we do input. So my concern is, of course, if we have a child, there's, you know, a child, pediatric patient, and actually the child is absolutely fine, but then of course for that child, the reasonable adjustment for them, if their parent had a diagnosis of a learning disability, it would be potentially having that information on the child's record. So is that something that you have on Maxims already or not?
It wouldn't be necessarily immediately obvious. I think Maxims unfortunately is a bit clunky and things don't jump out at you. But certainly we have related person on a, you know, if a child's record, you'd have a related person, then you can look at that person's record to see if they've got an alert. So that it is possible. But as I said, the system is a bit clunky and it doesn't really, you know, these things that you want to almost jump out at you, don't you? Because you need to know them as clinicians is not always, you know, but I mean, it's better than nothing. So short answer is yes, there can be a link.
Okay.
But you've got to look for it. So
yeah, okay. So maybe that's something that we will have to do a little bit more work around.
As I said, I'm really happy if there's individuals that want to be discussed. You know, you want to just look at some specifics, you know, we can be contacted either email or phone or okay.
Okay, thanks.
So next, are we on the next slide? Sorry, I've got lost now. Oh no, next slide, please. Okay. So we've covered this really, but it is about that early identification, because the sooner, this is our experience, the sooner you've identified you need to adapt your style, we're already breaking down those barriers, and we're giving those parents or potential parents the best chance of learning in a style that suits them, a way that's best for them, and giving them the best chance to parent successfully, or at least engage with the process. That's our key takeaways from this. The reasonable adjustments, again, we've talked about, what can we do? What flexibility can we give? What ideas that, often our people that use our services often have their, some really good ideas, about how to give them information, what works for them. I have support on a Tuesday morning. I don't have support any other time. My carer doesn't come. So actually an appointment on a Tuesday morning when my carer can come with me would be much more beneficial. So, those sorts of things. Multi-agency collaboration, again, it's about getting the right people to wrap around that person to support them from the outset. Who's there already for them? A lot of our patients have really good support networks out there. They have care agencies that have been supporting them for many years and know them really well, that sort of thing. So it's really important. We've got a parenting case going on at the moment, and those two parents both have ALD, and they've both been supported by the same agency for 15 or whatever. So they are a really useful support mechanism for those parents, and part of the process. Professional curiosity, we talk about this in safeguarding all the time, and I think we just have to keep that very forefront of our minds with this subject we're talking about as well today. We need to understand the process. I think that's part of the problem sometimes, isn't it? And Natalie touched on this, sometimes it's complex for us to understand the pathways and processes. So how can we represent those to people we're supporting if we don't understand them ourselves? And I think that's quite a big barrier. And things change constantly, don't they? Guidance changes, teams change, like we've said, it can be very fast paced and hard to keep up with. Transparency around decision making and capacity. This is really key. It's about honesty, and I think, again, I've had experience with parents where it's come a great shock to them, 3/4 of the way through a pregnancy, that they're under child protection proceedings, and they don't feel like they've understood the process all the way along, and that's really sad, and that's down to us as professionals. How have we got to this point, and they don't really know what's happening. Next slide, please. Okay, so just so I can wrap up that last slide, really, I think now before we move on to this one, it's about making fair adjustments, doing fair assessments based on the person's individual needs, so that we give them the best chance to parent that we can. And if we've done all of that, hand on heart, the things that I've mentioned today, and they then aren't able to parent adequately, they've had their best chance of that, and we can sit and say, well, we've done everything in our power to try and make that situation viable. And my experience over the years has been that we've missed bits, and then that doesn't feel fair. Okay, so person-centered support, this is what all of us, on this call, it's what we do. That's why we're here. That's why we do the jobs we do. And I think there's a lot of repetition in what I've already talked about here. Somebody's already mentioned, and I think that's really key, sometimes you'll have parents with a learning disability. There's a strong likelihood that the child then may have a cognitive impairment as well. you know, and I supported a lady for many years. She had a child, she had learning disability. The child had the same genetic learning disability. So the role supporting her changed from supporting her to understand her pregnancy and looking after her child to then supporting her with her child's journey through healthcare, because she needed those adjustments made so she could continue to parent that child safely when the child had medical needs around the learning disability. So, you know, it's complex, but that's the person-centered element there. Things like we've talked about pace of delivery, we've talked about time, we've talked about environment. You know, some people find coming into clinics or hospitals very anxiety provoking. They might prefer to meet somewhere, you know, less anxiety provoking. They might prefer to meet at home. Someone might not. That lady I talked about, she didn't like meeting at home because her mum was quite overbearing in the conversation. She didn't feel like she could talk openly. So these are all the things we do, and we do it every day, but I think we're just touching back on it today. Early advocacy, I think I touch on this on another slide as well at some point, but you know what we've also experienced is some of those, you know, that end up with legal proceedings, the advocacy comes quite late. And I think advocacy for those parents is really important early on, you know, and I think sometimes we're a bit held up that we can't request advocacy and the funding for it until we get to a certain point. And then there's often a delay. So my experience is the advocacy sometimes comes in later than we would want. We've talked about networks around the people, and I think that's up to us as professionals to strengthen our networks before we get to a point where we're supporting a parent. We've talked about accessible information and capacity, considering their capacity throughout for specific decisions, you know, and I think sometimes that is the sort of ball that gets kicked into the long grass because no one really wants to tackle it and take it on and take responsibility. But we need to establish quite early on what someone's understanding of this process is, so that we know that, you know, whether we're continuing with them having an understanding and making decisions for themselves, or whether we're starting to look at a best interest decision on their behalf and who needs to be involved in that. And that's same for any intervention. I think I've covered that one. So next slide, please. Again, mental capacity assessments, and the Mental Capacity Act is a whole big training session in itself, and I'm sure many of you have accessed that. But I think it's good to just anchor it into a slide here, because obviously it's fundamental to decision making for that individual that we're supporting. Now, the first point there is presumption of capacity. I always assume that someone can make a decision for themselves unless proven otherwise. There's a caveat there. If someone has a cognitive impairment, for example, a learning disability, we should always consider that we need a capacity assessment. They may have full capacity, but it is right to stop and decide that we may need one because they have a cognitive impairment. That could be mild, it could be, you know, significant, but that is where we are at that point. They should be supported to make decisions. We should ensure that we have given information in those accessible ways in a timely manner, you know, without jargon and all of those things, to support them to make decisions for themselves. The decision must be, the capacity decision must be decision specific. So if you're assessing whether, you know, I'll pick something that's not necessarily relevant here, someone is safe to go and use public transport without a carer, you know, that is, you might even be as specific as oh, well, they're used to using a bus, but they've never been on a train before. So the decision might be about safe use of transport alone. That is a train, because, capacity decisions, some people can make simple decisions for themselves, what they have for tea, cheese sandwich or beans on toast, but a complex decision around their health or a court proceedings, whatever the section is, when a child's going into looked after service, that's a much more complex decision that they might need more support with, or they may not be able to make. So that's when it says decision specific. I hear all the time, oh, Mary's not got capacity. What's she not got capacity for? Can she decide if she wants to go out in the car or not? Oh, yes, she can do that. Well, then she's got capacity for that. So we mustn't have blanket capacity decisions. And I apologise if I'm preaching here and people, know this already. But in this context, we must remind ourselves people can make unwise decisions if they have capacity to make them. We can do nothing about that. But the important thing is we work out whether they understand the risk. And best interest decision making is the part where everyone is agreement that capacity isn't there for the decision. And then we look at how we progress in the person's best interest. Also to say if the person doesn't have any independent person in their life, a friend or a family member that can support that best interest decision making, they may need an advocate. So again, that's another whole sort of topic, but that's just a whistle-stop tour to put that in context from our discussions today. Okay, next slide, please. Okay. Yeah, this isn't all. I've probably covered all this. Just to say, if you are making best interest decisions for somebody collectively, you should always look at the least restrictive option. The records should be robust around the capacity assessment and the best interest decision making. People could have fluctuating capacity. For example, someone with dementia, they could have a good day, they could have a bad day. So this is why it needs to be time and decision specific. We might need to revisit involving family carers and advocates I've talked about, and independent advocacy. Okay, right. Next slide, please. I'm trying to make sure we get through it so we've got time for a discussion at the end. Pathways and processes. I'm not going to go through all this, but I think this is a takeaway really from today. It's about us making ourselves aware of what services are there, how we can multi-agency work and make those key networks, so that if we have a parent with learning disabilities, we know what process, make ourselves fully au fait so that we can support them with the process. And I'm very keen, with my experience with parents with learning disabilities, we're not reinventing the wheel every time we come across a new one. It's about, okay, we've done this before, we've learned from our mistakes, let's get it right this time. And that is really about what this slide is about. So I think, I'm very keen to have continued conversations with services, because we can then build those stronger links to support those parents and families going forward. Okay, I think we might have got to our next question we want to pose to the group. So what approaches or adjustments have you found most effective when supporting parents with learning disabilities, and how could these be embedded more consistently across our practice? And I think there were some really good things in the first chat. So I think if we can build on those, it would be great. So over to you.
So again, feel free to put your hands up if you sort of want to share any thoughts or any good, some examples of good practice and things that you've done, or feel free to pop in the chat and we can read those out. No one's brave enough to put their hand out. Or it could be that you've already shared it. Like you said, Jane, we had some
Yeah,
good
I mean,
examples in the
just
last one,
from
didn't we?
just from my point of view, it's interesting to know how many people on the call really have been involved in parenting cases with parents with learning disabilities, because this could be an audience where they've not had that experience. So,
Yeah.
they may not be able to contribute to this because they've not had that experience. But I'm just interested, you see.
Yeah, Angela?
I have mentioned earlier, but I'm just wondering, I've not, I don't do direct work with families, but we have had to adapt letters and things like that to go out to families in different contexts. And I have started to use AI to try to adapt the language for those. So putting things through, Copilot and asking it to either write it, for a certain age level or, the different adaptations. I'm hoping that that's acceptable. That's considered
I
a
think
practice.
that, yeah, and we're all moving that way, aren't we? And certainly our LD team, there's a specific, and this actually might be quite useful. We had a team away day last week, and I didn't even know about this, but there's an app called Gremlin. It's a funny name, but actually it's an app that you can put a task in. For example, have a shower, make a sandwich, and it will break it down into manageable bite-sized stages. So ROTs find it useful, for people that, they're looking at functional skills for people. So, that sort of thing, we can be using that because, and you can say to Gremlin, apparently, it'll give you, I don't know, 5 bullet points for making a sandwich. And you can say, that's still too complex. I need you to break it down further, butter the bread. Well, get the butter out of the fridge, get a knife out of the drawer. So, those sort of things, they're there. I know people have mixed feelings about AI, and we have to put the human element back in, but certainly as a tool. And so for those easy read, documents, and a lot of us have it now embedded into our work computers. It's not like we're putting patient data into ChatGPT on our phones or whatever. So I think if they're there, that's a really useful, and those are really good things to share across services. That's how we, someone's used that and then they can, so I didn't know about Gremlin, and actually if I have to work with a parent with learning disabilities, it might just be about nappy changing or bathing. Even the resources I've put on might be too complex. If you could break something down that, and you can ask Copilot, can you put some pictures into this? It, like you say, and I think that's really useful to share. So thank you for that. That's really helpful.
And we've got another hand up to James.
Oh, it's Mandy actually.
Mandy,
so we're
sorry.
just sharing here. It's just to say that for us, obviously working directly with families in their homes, it's about that ongoing relationship and building the trust, but also really understanding the parents' needs, because yes, we've been in some very challenging, difficult, really challenging situations with families around parenting and around what the next step is. But it's actually part of our work is really sort of unpicking that. So where you're looking at the little and the small steps and how it really works for a parent, that we really try to do that. And working with many different parents, mums, dads, partners, and looking, like I say, when they're setting up home, when they're getting prepared to have baby and ready for baby, putting all of them, supporting them at their level and pace that they feel is right for them, and then being alongside to support them in that parenting journey, and feeding into obviously all the multi-agency meetings we also do, but providing that advocacy and voice for the families is really important to us and to them. So yeah.
That's a great example. Thank you very much for that. And yeah, Caroline, got your hand up? Can't see Caroline. Oh, you're on mute, Caroline.
Is that better?
Yeah, can hear you now.
Yeah. I'm Caroline. I'm one of the epilepsy nurses for paediatrics in Hereford. My background is actually LD as well, so I know both of the ladies that are presenting very well today. One of the biggest challenges that we have is that a lot of our parents that have learning difficulties sometimes have difficulty understanding the doses of the medications as well. So we spend a lot of time face to face because a lot of our medications come in lots of different doses as well. So that's why we have difficulty sometimes. So a lot of the parents will say, oh, we give 2 tablets at such and such a time and 2 tablets at such and such a time, which is great, but we need to know what dose those tablets are as well. So we try and spend a lot of time with those families face to face if we can, to try and make sure that we don't have issues with doses and tablets. And unfortunately, if the GP doesn't write a specific brand of medication as well, they'll quite often change the branding. And it's really, really important that we stick to the same brand. So we have lots of issues with that in our role. So just something to be mindful of. And any pointers that you can give us, Jane, that would be brilliant.
Yeah, and I think it's common, you know, people getting discharged from the acute hospital and they go home with medications in a bag that they don't understand how to take. And no one's thought that through. So they either don't take them or they take them wrong or too much or too little. So yeah, I mean, it is very common, isn't it? And I think, you know, it is each case as well, slightly different for different, you know, it's hard, isn't it? But yeah, it's just about finding that key support and what works for that person, isn't it? But you know, you always know where we are, Caroline.
Oh, I do. Thank you.
I think also one thing that I didn't mention, which I think is, you know, from the sort of parenting process point of view, you know, we've had, and this isn't just the recent couple that we've worked with, but they've seen the process as judgmental, you know, and I think that can often feel that way for any parent that's sort of coming under this spotlight, can't it? But they perhaps don't see the benefit of something like attending a meeting or the, you know, it's about how we show them why we're asking them to do certain things, you know, and a prime example is things like when they have to have a cognitive assessment for the legal process, they feel that's a test. It's a test about, you know, am I going to pass or fail? But actually it's about, that's a positive thing. We need to understand how you learn so we can help you parent in that style. But I'm not sure that gets explained to them. So they don't turn up, you know, and I think that is something about their understanding of the process rather than their not willing to engage, and it gets labelled wrong. And I get, you know, I get a bit, you know, on my soapbox about that. So, you know, that's just something that came to me while we were chatting there that I think is just worth mentioning.
Yeah, really important point. We've got quite a bit in the chat as well, so thank you for everyone. So offering private spaces for clinical appointments, so avoiding busy waiting areas and sensory overload. Definitely working as a team to provide appropriately timed information in an accessible way. Yeah, definitely. I know obviously we've sort of focused on learning disability, but just sort of wanted to highlight because we brought this up on a training course a couple of months ago, and we Googled the average reading age of an adult in the UK, and it's actually between, I think it was 9 and 11, 9 and 12. So just in terms of how we're presenting information, yeah, it's really important. Like Angela said, the use of sort of AI there can be really useful. Have written up details of meetings, appointments in a simple format to share after for information and next steps. Yeah, definitely. And within children's services, I've seen some really great practice where one social worker had written a court report, which is obviously very complex. It's written so the judge can understand, and very, very complex report, or a parenting assessment, which again can be really, really complex. But what they did was a really simplified summary for that parent that they could sit and go through with them, so that parent could take that away and read that and still get all of the information they needed, but in a much more simplified version. Which was, I thought, was really, really good. Trunking information, taking time in clinics or with conversations, checking information given is understood, and asking if they want companion with them. Yeah. Continuity of carer. I supported a parent with visual timetable of where our visits were, and also provided a visual explanation of the process of our support, but also sat with the parent and went through it step by step. I'm just conscious of time, so just whizzing through these. Which had lots of pictures and reduced the amount of complicated words and sentences. And thanks for that, Charlie. And not heard of Gremlin. I'm going to have a look. Not used either, but it seems to be something we could be effective moving forward. Yeah, definitely. So thank you that for everyone. Some really good points raised there again.
I think, sorry, I've just thought of something else. This is me now, you can't shut me up. But also things like, for maternity services, now it's all like on BadgerNet, and there's an app on a phone, which is great for a lot of mums. But for some of the mums we support, or the parents we support, that's really difficult to navigate, and I've had calls saying they're not turning up at appointments, but they don't understand how to use the software. So and you don't want parents being judged for not engaging, if actually it's what we're doing that isn't enabling them to engage. And BadgerNet is a really good example of that, and the struggles that it so sorry, I just thought I'd chip that in once.
Thanks, Jane. And then I think our last one. So we're at the end, Kirsty, but just any questions from anybody?